Welcome to Collaborative Intensive Bridging Services, otherwise known as CIBS. CIBS was a service developed particularly to help at-risk youth and their families. Now, these children were typically the type of kids who would go to long-term residential treatment centers. And back in 2009, Dakota County was experiencing just that situation. Many of their children were going into residential treatment centers and were staying there longer than expected, or they were going in for multiple episodes of treatment. And Dakota County asked the question, how can we do this differently? The result was the formulation of the CIBS model. Now, CIBS is pairing intensive in-home therapy along with a short-term residential program and merging these two together to provide a brief integrated services for youth and families, really trying to minimize or stop problem behaviors that these youth are exhibiting. There's actually 3 phases to the CIBS program. In the first phase, an intensive in-home therapist goes to the family's home and begins a 2 to 3 week assessment process with the family. In this situation, the therapist is gathering information from both the family, the child, other systems who might be involved with the family, including people like referral sources. It could perhaps be school personnel. Really, wherever the child and family are interacting, we want to know information about that will help us better understand the situation with them. During that 2 to 3 week time frame then, the therapist is formulating their hypothesis or their best guess as to what are some of the things that are affecting some of the current family functioning. One of the most significant shifts you'll see in this type of work is that although we are working intensely with the child, it is really the family system that is the focus of treatment. So by the end of that first phase of treatment, we want to have the RTC answer some pretty specific questions about what's going on currently for the child. The therapist that started in phase 1 will continue during this 30-day time frame at the RTC. What also occurs during this time frame is that the in-home therapist staff works closely with the RTC staff. Oftentimes, RTC staff may be providing co-therapy during this time frame. We'll be providing frequent contact with the family regarding their child's progress there. There's usually 3 staffings that occur during that time frame at the RTC, so the family is well informed about the progress being made there. One of the things to note about this experience is that children within a 30-day time frame typically are not fixed. They are, though, exposed to certain skills and are expected to practice those both during their regular day at the RTC as well as during home visits. And home visits occur on a frequent basis during that 30-day time frame because we want the kids and families practicing the skills necessary to help them be more successful back in the home setting. After the 30-day placement, the child goes back into their home. And then there's, in phase 3 then, it's intensive in-home therapy follow-up, which occurs typically 6 to 7 months following that second phase of treatment. During this time, the same in-home therapist that started with the family continues the work with the family to continue to solidify the gains that were made during the earlier phases, as well as the ongoing work that is necessary to cement the changes that have occurred in a more permanent way with the family. Hello, and welcome to our ongoing discussion about Collaborative Intensive Bridging Services, otherwise known as CIBS. CIBS is a intensive in-home program coupled with an RTC component that really tries to help stabilize kids' behaviors in the home and the community. And we're talking particularly in this segment about the case manager role. Case manager plays an important role in the overall process of treatment in CIBS. And we have a couple experts to share with us today their perspectives on doing the model as a case manager. With us today we have Sandy Tupy, who is a case manager at Dakota County, and we have Mark Oster, who is a supervisor at Dakota County. And they have been helpful in helping to pioneer this program. So welcome to the both of you.
Thank you.
Thanks, Lou.
I wonder if you could talk a little bit about CIBS, particularly maybe the difference between CIBS and case management services as usual.
Well, from a case manager's perspective, I think the difference is that as a case manager, you are more involved. You're more active with the family and with the therapist that's running kind of the therapeutic process, and RTC. So I think that you're collaborating more, and that is a very active role in trying to connect with everybody and trying to make the process go smoother.
Okay. Mark, I'm wondering if you could give us a brief overview of the case manager's role in these types of cases.
We look for the case manager to be the support to the family and the child. What's a little bit different, I think, in CIBS cases is the intensity that the case manager is having considerably more frequent contact with parents, both face to face and by phone, as well as the other team members, the facility, the in-home family therapist, and the family.
Mark, from a supervisor perspective, what are you looking to see your workers do maybe differently when they're involved in a CIBS type of case?
Working with CIBS is a very intensive process. And so that involves having a higher level of communication really with all the parties in the case. So the parent or caregiver, the child, the treatment team, the facility staff, as well as the in-home therapist, that you're at the hub of keeping all these parties working together toward a common goal and outcome that you're trying to achieve, moving a child from a place where they're not functioning in a safe way in the community to developing skills adequate enough that they can work on other goals while they're back in their family home and in community. So there's more intensive supervision involved. There's regular meetings, intensive communication between all the parties, keeping everybody going in the same direction.
Right, right. I'm curious how families have reacted to this, because there are certainly a number of families who the involvement of social services is not something they feel good about, and so may want to maybe distance themselves or not be as much a part, but this really is a process where they're being drawn in more, and obviously case managers are more involved. Can you talk maybe a little bit about how families have reacted to that?
Well, I think some families have been really great and have been really embracing of the process and really want to make change and want to see the family grow and have the child reunify back with them. And then there's other families where, they really don't want you in their business and they really don't want that many team members. There's too many. So that's been the challenge, is really trying to help them understand and clarify for them that this is a short process. We only have 45 days intensely when the child's in the RTC to really address these issues and get at the barriers that are causing the problems with the child's mental health that's keeping them from being safe in their home.
Right, right.
Yeah, I kind of see it as a balance in two directions. That for some families, it instills so much hope to think that, wow, we can get moving along and have our youth back with us in a short period of time, that the very focused kind of goals helps them think we can do this, and they're hopeful that they can move forward. But it's intense and it's demanding, so that's hard for a lot of families, to think the amount of time that it's going to take over a 3-month period, leading up to, during, and the weeks after, can be a bit overwhelming for people. But I think once they get into it and they experience that change happening right away versus a message that your child may need to live away from you for a half a year or more, it's that balance. I think what we've learned is if you start before a family's totally exhausted, then they're ready to say, it's easier to feel hope. And I think that's one of the strengths of the program, that we're more likely to try this intensive service earlier before youth functioning deteriorates so much, versus the risk of saying, okay, we're going to invest in a long-term RTC and send a child away for 6 months, 9 months, a year, which is a traumatic experience. I think we were reluctant as a county to do that. And so it's kind of a mixed bag. But I think once you get into it, if you can get investment, then families do have that feeling of, we're making change, and we're part of making that change, so they're hopeful.
Yeah. And I was thinking about, the important role that the case manager plays in this process. You, and particularly the county, are really the first point of contact in regards to this service, meaning oftentimes families are coming in, bringing their concerns or maybe their desire to maybe have the kid placed out of the home given their level of behavior. So really you are the first level of contact. And so maybe talk a little bit more about how you've tried to present CIBS to the family, and so that they understand the process, as well as maybe help them understand that there's a alternative they could do besides residential placement.
Well, usually when families do start to get to that point where they're talking about having their child placed out of the home, is usually when I start to bring that up before it gets to that extreme level. I'm just done. A lot of parents just say, I'm done, I'm not doing this anymore, and think that the county is going to be able to help them manage their child. And with that, I think what has happened is that with that conversation, we talk about how this can be a process that's jointly made, that it's a shorter term process, and that the results are better, and that they're closer to home. Oftentimes the other RTCs are farther away, and so connecting is harder, and the child's just farther away. And so I think that families have a harder time thinking, oh, how am I going to get up to that city to go and try to meet with my child? Yeah. So I've noticed that as a difference.
Yeah. And I think, Mark, if you could speak maybe to, even though the county is the first line of contact usually in this, is the need for kind of repeating the message multiple times regarding the service, what's involved. I know case managers are often involved in ongoing conversations with the family about that. And that's not just a hit them once with, this is the program and it's a done deal. Could you talk a little bit about that?
Yeah, many of the families that eventually use CIBS are families that have case management over a period of time. Others may come to us because their child was hospitalized, and during that hospitalization, the hospital refers them to case management, and we get involved at that point. So there's kind of two camps. One is families come to us in crisis, and when assessment is done, either by a community mental health professional or a hospital, recommendations being made that they need a higher level of care. In those instances, a lot of people aren't necessarily aware that we have this model of intervention. And so in those instances, there's education involved with the hospital, with any treatment providers that have been involved in the family, payers, family's insurance company, to say, we have this service that we're having really good outcomes with. And getting all the parties to say, wow, this is a possibility. In some of those instances, residential treatment there aren't beds available. And so by starting with systemic family therapy, which is the beginning component of bridging, allows people to kind of get started, even though they might be not totally invested in the idea that they're going to do the full bridging. And they get started and see that beginning of change and have hope that maybe this is the right thing for my child. So there's that group, and then the other group would be families that we've worked with for a while, and maybe they've gone through different crises as their child's gone through different developmental stages or events have happened in their life, and it's an education process. Really contrasting a longer term placement versus this model.
Right. And I know, Sandy, you had mentioned earlier about the increased involvement that typically a case manager has in these types of cases. Maybe can you speak particularly, I think the RTC phase is probably one where you're having regular contact either through staffings or meetings that occur around that. Could you maybe talk more specifically, how involved is that for a case manager?
Well, I would say that actually in this model, you are more involved in the sense that you're connecting, with the systemic family therapist, you're connecting with the family, you're going to the RTC, you're still having contact with the child separately from the rest of the team. You're also connecting with the primary case manager on the milieu, which I think is an important piece as well. Kind of finding out the day-to-day kind of challenges that they're facing, and then trying to bring that back into the team at the staffings and addressing it. So I feel like I am very involved in many aspects: phone calls, contacts, supervision, connecting with my supervisor and addressing, the concerns, or how do we move this along? I feel stuck in this area right now, or the team feels a little stuck here, so how can we move this along a little bit more? And really clarifying for the family and being part of that advocate for them,
Right.
as well as they're trying to figure out, because they don't understand RTC, they don't understand everything, so trying to help them and clarify what their role is as a parent. Can they have a say about some things when, RTC is making a decision about something? Can they have a say about that? Can they, ask questions? So a lot of clarifying, a lot of helping them understand,
Right.
and bringing messages to other team members, sometimes where parents don't feel they have a voice or feel like they can say something. So doing a lot of that.